All right. So a very good evening, everyone, and I wish you a very happy Diwali and a prosperous year ahead. So, with this wishes, let me just start the today's session. So, the today's session will be the clinical-based questions on the pulmonology or the respiratory system. So all of the questions will be very interesting questions, right? Yes, Avinash, happy Diwali. And I definitely appreciate all those students who are attending the session right now. So being festival day and you are showing that much interest to attend the session is really enthusiastic for me to teach, right? Now, so you may get little disturbance of the cracker sounds, right? So please bear with that. Okay. So now let us start with the session. So the today's session is completely the clinical based questions on your pulmonology. And all the questions will be very lengthy questions, right? And you also have image based questions in this. And let me tell you, all the questions are very, very interesting questions. And all the questions are expected questions in your upcoming FMGE exam or the INI CET exams. All right? Right. So with this, let me start with the session. Okay. So the first question is, right. So we have a we have 25-year-old man is brought to the emergency department by ambulance after his family found him unresponsive at home, right? Unresponsive at home. He has history of intravenous drug abuse and HIV with medical non-compliance. So even though he has the retroviral infection, he is non-compliant with the medication. And CD4 count is less than 200 per microliter. On initial evaluation, his blood pressure is 120 by 75 millimeters of mercury, and the heart rate is 105 beats per minute. Respiratory rate is very, very less, right? That is 8 breaths per minute. Oxygen saturation is 83%, temperature is 36 degrees centigrade. A blood gas on room air reveals 7.16. That means acidotic. Partial pressure of the carbon dioxide of 70 millimeters of mercury and partial pressure of oxygen of 55 millimeters of mercury. Which of the following is the most likely diagnosis? Asthma, narcotic overdose, pneumococcal pneumonia, pneumocystis pneumonia, pulmonary embolism. Yes. Can anyone answer this question? So what are all the positive points? Yes, Avinash says pneumocystis pneumonia. All right. Okay. So the very important positive points, this patient is HIV infected and CD4 count is very less. And you take the respiratory rate. Respiratory rate is reduced. Avinash, please tell me, in your PCP pneumonia, tell me, is the respiratory rate reduced? The respiratory rate is 8 breaths per minute. So please tell me now, respiratory rate, is it reduced in case of PCP pneumonia? All those whoever has answered D. Respiratory rate in case of PCP pneumonia, what will happen to the respiratory rate? So remember, in case of pneumocystis pneumonia, the individual will have tachypnea. Right? The individual will have tachypnea. But what is this individual is having? Bradypnea. The respiratory rate is reduced. So it is very unlikely to be pneumocystis pneumonia. Right? It is unlikely to be pneumocystis pneumonia. Right? So either there should be tachypnea or in early stages, okay, very good Avinash, it can be normal respiratory rate in early stages. But bradypnea will not be there. in case of your pneumocystis pneumonia. So that is the reason why your pneumocystis pneumonia is ruled out, right? Pneumocystis pneumonia is ruled out. Now, yeah, can anyone tell me what is the other alternative answer? So your pneumocystis pneumonia is not the answer. Then what is the alternative answer? Any one of you? Yes. So among the options given to you, which is the one which is a respiratory suppressant? That is your narcotic overdose. Narcotic overdose, that is the one which is a respiratory suppressant. Right? Narcotic overdose is nothing but your opioids. What does the opioids do? Opioids are the one which will cause respiratory center suppression. So because of this respiratory center suppression, the respiratory rate is reduced. So once the respiratory rate is reduced, what will happen to the partial pressure of the carbon dioxide? Partial pressure of the carbon dioxide will be increased. So once the partial pressure of the carbon dioxide is increased, that makes the individual to develop what is called respiratory acidosis. Right? Respiratory acidosis. So 7.16 pH and PCO2 of 70 millimeters of mercury. So 7.16, this is an acidotic pH. And 70 carbon dioxide, that is your hypercapnia. Right, this is your hypercapnia. So the answer is narcotic overdose. You take in all other condition, either you take asthma or you take pneumococcal pneumonia, pneumocystis pneumonia or pulmonary embolism. In all the other conditions except narcotic overdose, they will have tachypnea. There will be carbon dioxide washout. Right? There will be carbon dioxide washout. Okay, so they will not have the bradypnea 8 breaths per hour. So that is the reason why the answer is narcotic overdose. That is the reason why the answer is narcotic overdose. Now, what is the point in favor that tells you it's a narcotic overdose in the history? Now, you take the history, the individual has intravenous drug abuse. And that, what is that intravenous drug abuse? That is your narcotic overdose. So that is the reason why the answer is B. That is the second option, right? Now, so just by seeing HIV, and CD4 count less than 200, everyone was going with the pneumocystis pneumonia. But that is a trap. That's a trap in the question. Everyone will be thinking it is pneumocystis pneumonia, but it is not pneumocystis pneumonia, it is your narcotic overdose. So please be careful in these type of questions. You should not do mistakes, right? Next. We will move on to the next question. Okay, what is the drug of choice for your pneumocystis pneumonia? What is the drug of choice for pneumocystis pneumonia? Right. Right. So a lot of the cracker sound. I'm very sorry for the timing which I have selected. Right. But I'm little in a helpless state. Okay. Right. I'm very sorry for the timing which I have selected today. Right. So I can make out a lot of disturbance from the crackers and all, but I'm very sorry for that. Right. Now, this is another very interesting question. Okay. Always remember, the question is only lengthy, but the answer is very simple. Don't get scared. Don't get scared by seeing the length of the question. Understand the question, read the question thoroughly, and definitely you can crack it. Okay. You see now. We have a 65-year-old man evaluated for progressive dyspnea. Right? Yeah, evaluated for progressive dyspnea on exertion. Now, his medical history is significant for an episode of necrotizing pancreatitis that resulted in multi-organ failure. So he had necrotizing pancreatitis, and following which he had a multi-organ failure. And he also had acute respiratory distress syndrome. This history is also very important. Right? This history is also very, very important. And he required mechanical ventilation for 6 weeks prior to his recovery. He also has a history of 30+ years of tobacco, quitting 15 years previously. He is not known to have chronic obstructive pulmonary disease. On physical examination, a low-pitched inspiratory and expiratory wheeze is heard, loudest over the mid-chest area. On pulmonary function testing, the forced expiratory volume in 1 second is 2.5 liters, that is 78% predicted. Right, 78% predicted. And FVC is 94% predicted. FE1 by FVC ratio is 62.5%, that means it is reduced. And flow volume curve is shown in the figure. What is the most likely cause of this patient's symptoms? Aspirated foreign body, chronic obstructive pulmonary disease, idiopathic pulmonary fibrosis, subglottic stenosis, unilateral vocal cord palsy. Yeah. What is the answer? No. No, it is not. It is not unilateral vocal cord palsy. Now, you take this flow volume loop, right? You take this flow volume loop. This is your inspiration, and this is your expiration. Very good, Atul Shinoy. Atul Shinoy has answered it. The answer is subglottic stenosis. The answer is subglottic stenosis. Why? I will explain you. Now, you see the flow volume loop. Lower component, this is your inspiration, and the upper component is expiration. I'll just show you a normal flow volume loop. This is the normal flow volume loop. Inspiration, why it is on the lower side? Why? Because whenever we inhale, the air moves down. So, inspiratory component. Whenever we exhale, the air moves out. This is your expiratory component. So, inhalation going down, inspiration. Exhalation going up, expiration. This is the normal flow volume loop. Right. Now, you see in this case, what has happened? Inspiratory component is compressed, and even expiratory component is also compressed. Right? Both inspiratory and as well as expiratory, both of them, they are compressed. Right? Both of them are compressed. Both inspiratory component is compressed and expiratory component is also compressed. Now, in which scenario you will have that? You will have that in case of subglottic stenosis. Right? You will have that in case of subglottic stenosis. Okay. Now, what is this? Why there is subglottic stenosis? Why there is subglottic stenosis? Why there is subglottic stenosis is the individual was on mechanical ventilator 6 weeks prior to his recovery. This mechanical ventilation for 6 weeks, one of the complication is subglottic stenosis. Subglottic stenosis. Right? So this is the stenosis component, right? This is your stenosis component. That whenever in the trachea, whenever there is stenosis in the subglottic area, inspiration is reduced and expiration is also reduced. Right? Inspiration is reduced and even expiration is also reduced. Both inspiratory component, expiratory component, both are reduced. Why? Because there is stenosis, the amount of air which is entering is less. And the amount of air which is going out, this is also less. Right? The amount of air which is coming down is less. The amount of air which is going out is also less. Why? Because there is stenosis. Right? Because there is stenosis. And that is the reason why what will happen to the flow volume loop? The inspiratory component is reduced. Expiratory component is also reduced. Both your inspiratory component and expiratory component both will be reduced in case of subglottic stenosis. Now, what about the other clinical conditions? In obstructive lung diseases, what will happen to the flow volume loop? In restrictive lung diseases, what will happen to the flow volume loop? All that I'll discuss now, right? All that I will discuss. Yes. The pattern shown on the flow volume loop is obstructive pattern, restrictive pattern, normal curve, mixed pattern. Yeah, so please answer any one of you. The pattern shown on flow volume loop is, as already I have explained, lower component will be inspiratory component. And upper component will be expiratory component. That I have already taught in the normal flow volume loop. Right, very good, Gangula architecture. The answer is obstructive lung disease. The answer is obstructive lung disease. So in obstructive lung disease, the obstruction is during expiration. Right, the obstruction is during expiration. All right, so because there is an obstruction during expiration, right, because there is an obstruction during expiration, so what will happen? See, this is the normal expiratory loop. Right, this is the normal expiratory loop. So what will happen to the expiratory component? The expiratory component is reduced. Right, the expiratory component is reduced. So as the expiratory component is reduced, this tells it is an obstructive pattern. Right, this tells, yeah, this tells it is an obstructive pattern. Okay, why? Because in obstructive lung disease, expiration is reduced. Expiration is reduced. Okay, right. Now I will show you one more flow volume loop. Yeah, the flow volume loop curve shows COPD, interstitial lung disease, variable extrathoracic obstruction, variable intrathoracic obstruction. COPD, ILD, variable extrathoracic, intrathoracic obstruction. Flow volume loops are a very, very important area in your pulmonology where the questions can be asked. No. It is not interstitial lung disease. It is your variable extrathoracic obstruction. Right? It is your variable extrathoracic obstruction. Okay. It is not your B, it is your C. Now, what is the example? The example of variable extrathoracic obstruction is retrosternal goiter. Right, retrosternal goiter. So in retrosternal goiter, what will happen? This retrosternal goiter, it is behind the sternum. Right, it is behind the sternum. And this goiter, it moves down with trachea during inspiration. So that means what it will do to the trachea during inspiration? The goiter, right, the goiter will compress the trachea. Right, the goiter will compress the trachea during inspiration. Okay, whereas the goiter, it moves upwards. Right, the goiter, it moves upwards during expiration. Right, it moves upwards. Right, it moves upwards during expiration. So when the goiter moves upwards during expiration, the compression over the trachea is relieved. So expiration will be normal. Expiration will be normal. So that is what is your variable extrathoracic obstruction. So the example of variable extrathoracic obstruction is retrosternal goiter. And this goiter, it moves down along with the trachea during inspiration behind the sternum, and it compresses the trachea. And that is the reason why the inspiratory component is reduced. Right, the inspiratory component is reduced. Whereas during expiration, the goiter moves upwards. Right, during expiration, the goiter moves upwards. That means the compression over the trachea is reduced. So once the compression over the trachea is reduced during expiration, the expiration will be absolutely normal. Right, the expiration will be absolutely normal. Okay. So this is about the flow volume curve in case of variable extrathoracic obstruction. Right. Next. This is what is the same thing like what we have discussed, the variable extrathoracic obstruction. And you see this. So this is the flow volume loop of variable intrathoracic obstruction. Okay. Now, what is the example of variable intrathoracic obstruction? The example of variable intrathoracic obstruction include the presence of laryngeal tumor. Right, the presence of laryngeal tumor. Now, you see this is the trachea. Right, and this is your laryngeal tumor. Okay, and during inspiration, right, during inspiration, the air will push the laryngeal tumors towards the wall of the larynx. Right, we'll push the laryngeal tumor towards the wall of the larynx. So thereby, inspiration will be normal. Right, the inspiration will be absolutely normal. Okay, so because the inspiration is normal, so the inspiratory component will be normal. right? The inspiratory component will be normal, but during expiration, right, during expiration, when the air is moving out, it will push the laryngeal tumor, and thereby laryngeal tumor will come to a resting position. So thereby the air does not move out. Expiratory component is reduced. So when the expiratory component is reduced, this is the flow volume loop what you will get. Right, when the expiratory component is reduced, this is the flow volume loop like what you will get. Okay, yes, Asadullah, even your airway chondromalacia, you can have this. You can have this. Okay, so this is about the variable intrathoracic obstruction, right? And this is about your variable extrathoracic obstruction. All right, now, yes, this is another very easy question, but the question looks very lengthy, but the answer is very simple answer. 72-year-old man has been complaining of low-grade fever and dyspnea. So fever and dyspnea, these two are the very important symptoms. For 2 weeks, she has 10-year-old history of scleroderma and involvement of digits and esophagus. She has 30-year history of cigarette smoking, but quit 8 years ago. On chest radiograph, she has nodular infiltrates in the right lower lobe. PET or CT shows right lower lobe lesion to be 3 centimeters in diameter with nodular infiltrates characteristic and enhanced fluorodeoxyglucose uptake. Which of the following statement about Mrs. Wittstein is most accurate? The question asked is most accurate. Anyone? Which of the following statements about Mrs. Wittstein is most accurate? Achha, you are suspecting malignancy, Shabnam Khan. Any other answer? Any other answer apart from D? And there are 2 risk factors here. One, the patient is having scleroderma, right? One, the patient is having scleroderma, and second, the individual is a chronic smoker, right? These 2 are the important risk factors. Okay, let me tell you what exactly is the correct answer. Additional diagnostic studies are indicated. Your PET or CT scan will not decide whether it is malignancy or whether it is your aspiration. Now, let me tell you, based on the 2 risk factors, you take scleroderma, right? You take scleroderma. In scleroderma, there will be fibrosis of the esophagus. Right, there will be fibrosis of the esophagus, and because of the fibrosis of this particular esophagus, there is high chance of aspiration. So fibrosis of the esophagus, GI motility will be reduced. GI motility will be reduced, so there is high chance of aspiration. So what is the most common site for aspiration? The most common site for aspiration, it includes the right lower lobe. Right, the most common site for aspiration is the right lower lobe. And why is this aspiration very common? Because the individual is having scleroderma. Second point, the individual is also a chronic smoker. So there is a very high chance of malignancy in that area. right? There is a very high chance of malignancy in the right lower lobe. Now, what is given here? The FDG PET scan, it shows a lesion of 3 centimeters in diameter with nodular infiltrates. That means because the individual is having scleroderma, the chance of aspiration is high. And the other point is the individual is also smoker, and that is the reason why malignancy is also very common. So now what does this patient require? We cannot confirm whether it is an infection due to aspiration, right? Whether it is an infection during aspiration or whether it is malignancy, we cannot tell. So you require additional diagnostic studies are indicated. Now, what are those additional diagnostic studies? Right, so it is the additional diagnostic studies which are required is the fiber optic bronchoscopy. So fiber optic bronchoscopy, it will give you an additional idea of what exactly is the diagnosis. Is it an infection, right? Is it an infection or is it a malignancy? So that will be decided by the fiber optic bronchoscopy. All right, next. Yes. 1 second. We will come back to that question in the last. Yes. Yes. Now the question is single liner, but the options, they are like multiple liners. Which of the following patient is appropriately diagnosed with asthma? First option, 24-year-old woman treated with inhaled corticosteroids for cough and wheezing that has persisted for 6 weeks following the viral upper respiratory tract infection. First option. Second option, 26-year-old man who coughs and occasionally wheezes following the exercise in cold weather. Third option, a 34-year-old woman evaluated for chronic cough with an FE1 by FEC ratio of 68% with an FE1 increases from 1.68 to 1.98 liters after the albuterol. Fourth option, 44-year-old man who works as a technician caring for the mice in a medical research laboratory and complains of wheezing, shortness of breath and cough. Fifth option, a 60-year-old man who has smoked 2 packs of cigarette per day for 40 years, who has dyspnea and has cough and who has airway hyperreactivity in response to methacholine. So the question is, diagnosed with asthma. The answer is very, very simple answer, I'm telling you. Very simple answer. Only the options look very lengthy, but still you can crack the question. Right, very good, Chakri Kumar and Avinash. The answer is C. Right, the answer is C. Now, why do you think that the answer is C? Right, why do you think the answer is C? Now, asthma, we confirm the diagnosis by FEV1. Right, we will confirm the diagnosis by FEV1. Now, we will do a baseline FEV1. Right, you will do a baseline FEV1 in patients with asthma. Then we give a SABA, short-acting beta agonist. Right, you need to give a short-acting beta agonist, that is albuterol. Wait for 10 to 15 minutes. Then you need to check the FEV1. And here the FEV1 is more than 12%. We call it as bronchial asthma. Right, we call it as bronchial asthma. Okay, so how will you confirm? Yeah, so yes, more than 12% increase in your FE even with bronchodilator. That is the investigation of choice. Okay, so the answer is C. 34-year-old women evaluated for chronic cough with FE1 by FVC of 68%. That means reduced. With an FE1 that increases from 1.68 to 1.98 liters after the albuterol. Yes. Now we go to the next question. Right. A 53-year-old man is seen in the emergency department with sudden onset fever, chills, malaise, shortness of breath, but no wheezing. He has no significant past medical history and is a farmer. And off note, he worked earlier in the day staking hay. Postero-anterior and lateral aspect of the chest shows diffuse bilateral alveolar infiltrates. Which organism is most likely to be responsible for the presentation? Nocardia, histoplasmosis, Cryptococcus neoformis, Actinomyces species, Aspergillus fumigatus. Right, any one of you? So very interesting question. I'll be back in just 1 minute. Right, so the answer here is Actinomyces species. So what is this? Hay. Okay, the history is very clear. He has no significant past medical history and is a farmer. He worked earlier in the day staking hay. Right, that means priorly he had exposure to the hay. And after that, he has developed all these fever, chills, malaise, shortness of breath, but no wheezing. So, what is the organism which is responsible for this particular presentation is Actinomyces species. So, the diagnosis is what? Diagnosis is farmer's lung. Right, diagnosis is the farmer's lung. Okay, that's a very important point here. Right now, yeah, so he's a farmer and has recently handling the hay, and after this handling of the hay, all these pulmonary symptoms develop. Right, all these pulmonary symptoms have developed. Okay, and the farmer's lung, it is mainly due to hypersensitivity pneumonitis by actinomyces. Right, by actinomyces. Okay, so your actinomyces, right, that is nothing but your hypersensitivity pneumonitis. Right, hypersensitivity pneumonitis. Okay, so what is the organism for that? That is actinomyces. Right, actinomyces. And chest radiograph in case of hay fever, it shows bilateral upper lobe infiltrates. This is very important. Right, the presence of the upper lobe infiltrates. Okay, right. Now, yes, you see one more question. A 48-year-old man with a body mass index of 28.9 kg per meter square is diagnosed with obstructive sleep apnea with apnea-hypopnea index of 42 per hour and a minimum oxygen saturation of 78%. What is the most appropriate initial therapy for this patient? CPAP, oral application, oral appliance therapy, oxygen therapy, uvulopalato-pharyngoplasty, weight loss. Any one of you? What is the diagnosis? First of all, body mass index is 28, right? Apnea hypopnea index is 42. Oxygen saturation is 78%. So this is a case of obstructive sleep apnea. Right, this is a case of the obstructive sleep apnea. Okay, so for obstructive sleep apnea, what is the most appropriate, the initial therapy? That is your CPAP, right? That is the treatment of choice or the first line therapy. Continuous positive airway pressure ventilation. That is your CPAP, continuous positive airway pressure ventilation. Now, the severity of your obstructive sleep apnea, right? The severity of the obstructive sleep apnea is being assessed by your apnea hypopnea index, right? Apnea hypopnea index. Okay, so normal value is less than 5. Apnea hypopnea index. Right, and yeah, and if the value is less than 5 normal, no sleep apnea, 5 to 15 mild, 15 to 30 moderate, more than 30 is your severe sleep apnea. So what does our patient comes under? Apnea hypopnea index is 42 per hour. So this comes under severe obstructive sleep apnea. So in case of severe obstructive sleep apnea, what is the treatment of choice as a first line therapy? That is your CPAP, continuous positive airway pressure ventilation, right? Continuous positive airway pressure ventilation. Okay, that is the treatment of choice. Next. Now, the other point is, but what are the problems which are associated with the CPAP? These patients, they mainly complain of claustrophobia because it's a very tight fitting mask. The mask, it will tightly snug over the face, and that makes the individual to be claustrophobic. And there can be nasal congestion, there can be aerophagia, and there can be also facial pain. So these are the features like what you will have when the individual is on continuous positive airway pressure ventilation. But these complications, whatever are there, these are temporary and it can be managed accordingly, right? It can be managed accordingly. Now, if tolerated, there is large body of, okay, leave this. And oral appliance therapy. This is the second line therapy. First line therapy is definitely the CPAP, continuous positive airway pressure ventilation. But if you take this oral appliance therapy, it is generally considered the second line in mild to moderate obstructive sleep apnea. But what is our patient having? Our patient is having severe obstructive sleep apnea. When it is a very severe obstructive sleep apnea, definitely you need to go with the our patient is having severe obstructive sleep apnea because the value is 42. So definitely this patient requires CPAP, continuous positive airway pressure ventilation, not the weight loss. It is not the weight loss. Okay, and yeah, side effects of the oral appliances include the temporomandibular joint pain and as well as the tooth movement. And surgical interventions, they include uvulopalatopharyngoplasty. These are the surgical treatment, and this is the most common surgical procedure over the past 2 decades and is associated with a high success rate similar to that of oral appliance therapy. Which one? That is uvulopalatopharyngoplasty, right? So this is a very ideal method. Okay. And weight loss, definitely yes, it has to be recommended in patients with obstructive sleep apnea syndrome, right? Then we will take up one last question and then wind up. So I hope everyone has understood this question of CPAP. Just give me a thumbs up if everyone has understood this CPAP, continuous positive airway pressure ventilation. what is the indications for, like, okay, in individual, right? So if everyone is clear with this particular CPAP, yes, then we will move on to the next question. Last question for the day, and very interesting question as well. Yes, question looks very lengthy. It's also a very difficult question, but with the help of the CT scan, you should be able to crack the question. 62-year-old male is evaluated for dyspnea on exertion that has progressively worsened over the period of 10 months, and he has 50-pack history of tobacco, quitting 10 years ago. On physical examination, the resting oxygen saturation is 94%. After ambulation for 100 meters, that means after walking for 100 meters, his saturation drops to 84% after walking for some time. And what is the important history? Dyspnea on exertion. He requires oxygen at 3 liters per minute to maintain his saturation at greater than 90% with ambulation. His lung examination shows diffuse end inspiratory crackles throughout both the lungs. His total lung capacity is 72% predicted, that means reduced. Residual volume 68% predicted, reduced. Diffusion capacity is 60% predicted, that is also reduced. HRCT is shown here. Right, and serological workup for autoimmune disease is unremarkable, and thorough history yields no exposure that would lead to this finding. You suspect idiopathic pulmonary fibrosis, right? You have suspected idiopathic pulmonary fibrosis. What is the expected finding on the surgical pathology? So now, what is this entire story? This entire story, it is a case of idiopathic pulmonary fibrosis. Now, what is the expected finding on surgical pathology? That is, what is the question? Desquamative interstitial pneumonia, diffuse alveolar damage, loosely organized granulomatous inflammation and fibrosis, non-specific interstitial pneumonia, usual interstitial pneumonia. So, whatever you are seeing here, this is like honeycomb appearance. Right, this is like honeycomb appearance. So, where do you get this honeycomb appearance in patients with the idiopathic pulmonary fibrosis? That is in case of usual interstitial pneumonia, right? Very good, Avinash. So Avinash has answered it. Very good, Avinash. You have cracked it. Very good. So you will see that in case of the usual interstitial pneumonia, the answer is E. Right. Now, very good, Avinash. So if you see idiopathic pulmonary fibrosis is most common cause of idiopathic interstitial pneumonia. This sentence will crack the question. And what do they present with? They present with the progressive dyspnea and as well as the dry cough. And age of the individual is less than 50 years. Right? Age of the individual is less than 50 years. And whenever you examine, what is that you will listen? You will listen inspiratory crackles. Where is that? Yeah. End inspiratory crackles. That is very characteristic in case of idiopathic pulmonary fibrosis. The same way you see in the question also. The same way you see in the question also. On physical examination, there is presence of inspiratory crackles and clubbing are common. Pulmonary function test shows all the parameters being reduced. Low total lung capacity, low residual volume, low vital capacity, and low diffusion capacity of the lung for carbon monoxide. Right? Now, if you take the HRCT in case of usual interstitial pneumonia, HRCT in case of usual interstitial pneumonia, that will show typical interstitial fibrosis, presence of honeycomb pattern, presence of traction bronchiectasis pattern. That is what you will see in the HRCT in patients with the usual interstitial pneumonia, right? Next. Then followed by that. Then, okay. And what is the treatment for your idiopathic pulmonary fibrosis? The treatment for idiopathic pulmonary fibrosis is that we have two therapies. One, nintedanib. The other one is pirfenidone. The other one is pirfenidone. So pirfenidone and as well as nintedanib. Recently, these are the two theories have been approved by FDA for the treatment of idiopathic pulmonary fibrosis. Right? That is nintedanib and pirfenidone. Right? Pirfenidone. So what does this nintedanib will do? That will slow the rate of decline in the forced vital capacity. Right? That will slow down the rate of decline in forced vital capacity. That is what is being done by your nintedanib. And we have another drug that is pirfenidone. So what does this pirfenidone does? It is an anti-fibrotic medication that will also decrease the FVC, forced vital capacity, and it will also decrease the mortality within the individual. Right? That will also decrease the mortality within the individual. Right? Now, and you should not give glucocorticoids. You should not give immunosuppressants. You should not give N-acetylcysteine. Very, very important in case of idiopathic pulmonary fibrosis. So what are the two drugs in case of idiopathic pulmonary fibrosis? Number one, nintedanib. Number two, pirfenidone. Right? Number two, pirfenidone. Okay. So that is about the question on idiopathic pulmonary fibrosis. And idiopathic pulmonary fibrosis, one of the most common presentation is the usual interstitial pneumonia. So and what are the things which are telling that there is idiopathic pulmonary fibrosis? You can see the CT scan. Right? You can see the CT scan. There is presence of that fibrotic strands, and there is also presence of the honeycomb appearance of the lung. It is not present throughout the lung. It is present in the selective areas, right? And most commonly in the right lower lobe. Okay, so this is about your usual interstitial pneumonia and idiopathic pulmonary fibrosis. And these two drugs are very, very important. What are these two drugs? These two drugs include nintedanib and as well as pirfenidone. So with this, I will just wind up the today's session. So I will just summarize all the questions. I will summarize. I'll give you take-home messages. So in the first question, what is the take-home message? In case of narcotic overdose, there will be respiratory suppression and there will be respiratory acidosis. That's the take-home message of first question. And you take the take-home message of the second question. In case of long-standing mechanical intubation, there will be subglottic stenosis. And when you do a pulmonary function test, you will see a box-shaped appearance in the subglottic stenosis. Next. Yes. Now, this is a question on obstructive lung disease, where you have the obstructive pattern is compressed. This we call it as scooped out pattern, right? This we call it as scooped out pattern, right? Next. Now, coming to this question, the take-home message of this particular question is that this patient is smoker and this patient is also having the scleroderma. So, whether it is like malignancy or whether it is like aspiration due to scleroderma, in order to rule out, definitely you need to do additional diagnostic studies, and that additional diagnostic studies include the fiber optic bronchoscopy, right? Next. Yeah. So if take-home message of this particular question is that idiopathic pulmonary fibrosis, it will cause usual interstitial pneumonia. Very important point. And what does the HRCT shows? It shows the fibrotic strands. It shows the honeycomb appearance. Okay. And what is the treatment? The treatment is two important drugs for idiopathic pulmonary fibrosis: nintedanib and pirfenidone. So this is a take-home message related to your idiopathic pulmonary fibrosis. All right. Next. Now you take the take home message of this question. Bronchial asthma, after giving bronchodilator, there should be reversibility of your FEV1. FEV1, it will increase by more than 12% after your short acting bronchodilator. Very, very important question, right? Next. Yeah, take home message of this particular question is, whenever the individual is exposed to hay, what is the organism? That is Actinomyces species. That is a take home message regarding this particular question, right? Last question. In case of severe obstructive sleep apnea, the treatment of choice is CPAP, that is continuous positive airway pressure ventilation. So this completes the discussion of the today's clinical based questions. And in the upcoming sessions, I will come up with many other clinical based questions, right? So thank you very much. And I wish you again a very happy Deepavali, right? Stay safe mainly while burning the crackers, right? So I suggest not to burn the crackers and not to pollute the air, and stay safe on this occasion of Diwali. Thank you very much. And I wish you again a very happy Deepavali.